Welcome to Nurse Practitioners Changing Practice. I'm Carol Berger.
I'm Nina Zimmerman.
We are so happy to have you with us again for another episode of Nurse Practitioners Changing Practice. We are doing an episode today called Ranking Differentials, and I'm going to share my screen and we're going to go through a little presentation where we talk about an individual and the problems they're having, and we're going to try to figure out how that HPI looks and how we come up with our differential diagnoses, any additional tests, and come up with what we think the plan or the problem is. Okay, so bear with me while I share my screen and I get this all set up. Okay. All right, so let's meet Daryl. Can you see the screen?
Yes.
Good. Okay, this is Daryl. Daryl has come in to our clinic. He's 16 years old. And what he's told us is that he just started running track about 6 months ago. He wasn't big into sports before that. And he says when he gets to running really hard, he goes into a wheeze. And it's really kind of scary for him because his throat tightens up. He feels like he can't get air in. Feels like he's going to pass out. And some of the things that seem to help him are if he can just kind of relax and breathe through his nose. He has gone to the urgent care, but the urgent care only gave him an inhaler. And they've tried steroids and nothing really seems to help. He's tried using the inhaler before he starts exercising. He's tried with the attack and none of it seems to get better. So what we have up here for you is kind of old charts and a summary of how that would look, right? We have our onset, it's abrupt, located around his throat, been happening about 6 months since he started running. Feels like he can't get his air in. Exercise does make it worse. Nasal breathing makes it better. Happens only with exercise. And he says it's a 10 out of 10. He feels like he's going to pass out with it because it's so severe. So let's see.
And it's severe enough, Carol, that he wants to stop doing track. So it must be pretty severe and scary, right?
Yeah. So, I mean, the two most common things that come to my mind when somebody would come in like this would first of all be asthma. And then vocal cord dysfunction is not as common, but you have to put that in your differential list. And sometimes they can be, co-occurring. So let's see what he has that kind of aligns with these two differentials. And we'll talk about that. Wheezing would go more with asthma, right? And he calls it wheezing, but I'm not sure if it's really wheezing. Stridor sounds a little more like what he's saying because he can't really get that air in. What do you think, Nina?
Yeah, I definitely think that the key thing with the history is that he can't get air in, which can be with asthma too. And it could be, exercise induced. It could be he's got some kind of bad trigger allergy wise. Low on the differential could be there's some kind of obstruction going on in his upper airway. But yeah, Stridor's definitely more leaning towards vocal dysfunction.
And vocal cord dysfunction, definitely it's harder to get the air in. But as you say, when you're having trouble breathing, you're not really paying attention to whether it's hard to get it in or out. In asthma, the air is becoming trapped. But it might feel like you can't breathe. You just can't breathe. And so we have that throat tightness. He's talking that could go either way. That could go with either one. Change in the voice is more indicative of the vocal cord dysfunction.
Very, very key with VCD. Yep.
Cough could be either or. And as you said, exercise induced could be either or. So we've got two good solid differentials, right? That need a little further investigating, but I would lean more toward vocal cord dysfunction. We've got a couple clues. His inhaler and his prednisone haven't helped.
That's a big thing, Carol.
So that's kind of a big thing.
Yeah. The other thing is really delving into the history of, we asked when it started. Maybe it started when there's more stress in his life, but if he's had it for a while, typically these patients will tell you that they've gone to the emergency room several times. Sometimes the patients get, multiple prednisone bursts. Sometimes they're labeled as severe asthma patients or anxiety. So all that are keys that something's going on. And typically these patients, well, we're going to talk more about that, but there's more to talk about, which
So
I
yeah,
know.
let's look
you're
at
gonna
now.
talk
So of
about.
course, we need a
Yeah.
little help with this one.
Yes,
We're not
we
gonna
do.
be
We
able
do.
to diagnose this person on our own. We're going to refer them to ENT for sure, right? And they do some other tests. This is what we come back to find out. His pulmonary function tests are normal. That's
Mhm.
another key player, because in asthma, usually you'll see pre and post albuterol challenge, and there'll be an improvement.
Right.
And there's a
Right.
different sloping with asthma with that, but his pulmonary function test comes back normal. So
The
that
thing,
tells us there's an issue.
right. And the thing about pulmonary function tests, if you do just the spirometry and you don't do the bronchoprovocation pre and post albuterol, you may see normal function tests with asthma because it may be really controlled. So like Carol said, if you do the pre and post provocation with albuterol or maybe methacholine in some cases, you want to see a 15% change in their FEV1, FVC. So that's really important.
And that change would make us lean more toward asthma. But
Correct.
again, these can occur simultaneously. They
Mhm.
could have asthma and vocal cord dysfunction. That's even a harder one because they're getting
Yep.
some help from those bronchodilators, and yet it's still not going completely away. They did a CT of the upper airway, which was negative.
Mhm.
And then the ENT did a laryngoscopy to try to provoke the vocal cord to show some abnormal
Mhm.
function, and it was abnormal.
So that's a challenge too, because sometimes you'll get an abnormality with laryngoscope with provocation as an ENT to see that abnormal adduction of the vocal cords, but sometimes they don't see any abnormalities. So that's a challenge too, just to keep in mind. Just because they come back from ENT and they see normal laryngoscopy, you also have to talk to ENT. You want to send somebody to an ENT that specializes in this, because if they may not try to provocate or provoke the symptoms. So that's something to think about too.
Right. Just because you get a negative, it can rule it
Right.
in, but it can't necessarily rule it out.
Right.
Just because
Right.
you're normal, you have to listen to your patient and what they're saying and what's really going on.
Right.
So the winner is vocal cord dysfunction in this case, because we have dysphonia.
Mhm.
He has problems getting the air in.
Mhm.
We have normal pulmonary function test. Albuterol is not helping, and the steroids, which
Mhm.
he's gone to urgent care for. And so vocal cord dysfunction is what we come up with. So now, okay, we got the diagnosis. What do we do about it?
Mhm.
And this is one that's a little harder, because what's happening is the vocal cords are acting like they're paralyzed. They're just
Mhm.
they're not folding the way they should, and they're causing narrowing there. And that's causing the stridor, which sometimes you see in croup.
Right.
Sounds very croup-like, right?
Right.
And albuterol isn't going to turn it around.
Mhm.
So we definitely want to refer to a speech language pathologist, because they will help them with this breathing and relaxation technique. I think one of the interesting thing too was that nasal breathing helps. If they switch from mouth breathing to just trying to inhale through their nose and slow their breathing down and more diaphragmatic breathing, it will help that vocal cord area to relax. What are your thoughts?
Those are absolutely. Those are skills that need to be learned. They're not something you can just tell the patient to do. So that's why speech therapy, speech language pathology, that specialize in this to help them with adjusting their breathing and doing diaphragmatic breathing is really important. These patients are really anxious. So, you have to possibly deal with that too, address that. You have to make sure you tell the patient it's not in their head, because sometimes they're told that. Sometimes they're told, your pulmonary function's normal, you're going in and out of the hospital or the emergency room, and we're just not finding anything. So perhaps it's just anxiety, or it's just, you're having some issue there. So that's a really important thing to tease out. So sometimes also the research shows that these patients may have a history of sexual abuse, which we're not sure why these patients have a vocal cord dysfunction, but it is tied to patients who have had a history of sexual abuse. So certainly a psychologist, psychiatric evaluation will be really helpful with most of these patients. And as a matter of fact, it's good to talk about their history, a possible history of abuse in their history, if you are suspecting vocal cord. Now you have to approach that very sensitively, because you have a patient with breathing problems and they're wondering, why are you asking me about my if I've been sexually abused? So you have to explain that, but that may also give you a clue as to why they're having this abnormality of their vocal cords.
I'm going to stop sharing the screen now so we can just talk. That's our case, but it's so interesting. I mean, I can remember the patient that I had that had it, and just the points you brought up, Nina, are just so true. A lot of times they've just been to many doctors, and it's nobody has thought of vocal cord dysfunction. They just keep going down the pathway to asthma, and actually it can lead to their death. I mean, it can be severe enough that they just go undiagnosed and they have a really bad attack and they just don't get out of it. So not happen often, but it really is something that gets overlooked. And again, it can happen concurrently. So sometimes their albuterol does seem to help, and other times it doesn't. Right.
They could have asthma, they could have lung disease and vocal cord dysfunction. It's really good to find out when you refer. There may be asthma centers or centers that actually deal with vocal cord dysfunction with multiple team members there to help patients. In other words, they're able to properly diagnose the vocal cord dysfunction with laryngoscopy. They're able to do a psychiatric evaluation. They're able to do counseling. They're able to do speech pathology. So you may have those resources in your area, or you may have, if you're rural and you may not have that, or it's harder for the patients to get to an asthma specialty clinic that has all those factors. You may have to do some homework to find out, where you can send them for ENT first, and those things. So, that's all part of your experience. And just like we're telling you, we want to build on these cases in your memories so that if you have the situation, you may have to seek out these specialty referrals and those relationships. And because, this is not totally common. I don't have the percentages in front of me, but it is part of your differential. If you have somebody with multiple asthma attacks,
not getting much relief,
they're just not getting better. They're not working. They're not, they're stopping to do things that they want to do. Like this kid doesn't want to run. I mean,
and he's saying, hey, I might need to drop out of something that I really was trying out. That's altering his life behavior. And key things he's saying is his voice is high pitched. High pitched. His voice changes. So when you think of a voice changing thing, you're thinking vocal cords. It's affecting the vocal cords. So that's one key word that kind of clues you in that maybe there's more than just asthma here. And doing that thorough history and physical, finding out the environment, finding out past history, finding out parents' history, allergies, all of those things build the story of the patient. And we're as unique as each one of our patients. They are unique. And so that, it's not a one size fits all kind of world. So I thought you brought up some great points too. Don't always go by just saying it's a negative test, therefore it rules it out. It rules it in, but it doesn't always rule it out. Right.
That's right. And your case, we presented this case very well. And of course, just like we did the CT of the upper airway, of course, part of this would be, let's make sure there's no any kind of blockage,
Obstruction, tumor,
obstruction of the
anything.
airway, tumor of the upper airway. I've had that happen too,
Mhm.
where I thought, well, maybe it's vocal cord. And then when we did the CT, there was actually obstruction of the upper airway that we had to deal with. So that
So,
can happen too. Mhm.
yeah, so lots of good things, but these stories, we hope to bring them to you at least one every month is our goal. Once or twice a month, we'll have different cases to put up. They are housed on uh our website, npschangingpractice.com, and they are under a category all of their own called ranking differentials, so that you can see the presentation. And I have the references from up to date that you can look at to see what the official clinical practice guidelines are for this this particular scenario. And I thank you for listening. I thank you for your
Thank
comments. We
you.
thank you for your participation. We really want you to like, share, and follow our YouTube station. We
Mhm.
really enjoy that. So and any comments you leave us, we always read everything that's sent to us. And we thank you for being with us this week.
Thank
And we
you.
will see you again next week. Bye,
Bye.
everybody.